Great, thank you very much. And I want to just start by saying I feel really honored and happy to be here talking to you, introducing this, an overview for this topic. But I actually feel very warmly, generally, being in this room. And you know, it's not so common to be in the room with so many people deeply committed to vulnerable populations and caring about things that I care about, which is it's just a really very positive thing. And along the lines of why I feel so happy and proud to be here, besides the fact that people are deeply committed to a common cause, is the fact that there's a tremendous amount of social capital in this room. One of the things that really distinguishes our social capital is actually something that I think we could acknowledge as something called educational privilege. We have a tremendous amount of educational privilege in the room. And what I hope comes across from the slides that I share with you is a challenge that this field is. The challenge is, what are we going to do with our educational privilege? Because healthcare is basically run by very educated people, and it's our job really to drag that towards caring about, having everybody else care about vulnerable populations. So I was asked to introduce the topic of use, but the thing is, there's no use without access. And this is actually, it's really very important to point out that over the last decade, we have, at least in states that have agreed to do it, significantly moved the ball on access. And by moving more insurance access, that we actually significantly improve access for people. And there's almost no use, no proper use without access. But we also are going to be facing a tremendous cliff in access in terms of inadequate capacity in primary care. I'm a primary care provider, and it's just hard to not say that, you know, if we don't address that side of it as well, we really won't have succeeded in improving the access. We have to do both the financial side of it on both sides of the coin somehow, capacity on both sides. But once you're using the system, and however you do come to use the system, I think that really there's been a transformation in the field over the last decade from, as has been pointed out already, from focusing on individual skills. That's going to be relevant, but also to focus on the system. And one of the things that we can say, looking at all the literature that's evolved here, is that when you want to talk about access and use and delivery, that it's really important to use the lens of health literacy to do so. Really, in the end, the field has been able to show that health literacy ends up being a significant mediator in this nexus, in the connection between, you know, the relationship between individuals and systems, the use side and the delivery side, really has been shown itself to be an important mediator of very important core values that many of us hold. That is to ameliorate the effect of health literacy on equity, disparities, to be a lens through which we can promote patient-centeredness, improve outcomes, improve quality, and to reduce costs. It's really a financially perilous activity for people to ignore the effect of health literacy. There's been a move over the course of the last decade, really, which was dominated by observational work towards interventional work. But really, interventional work is still in its early phases, unfortunately. There's been a move from local exploration towards more some examples of broader implementation. And there's some good examples of this, but this is also an emerging science in and of itself, the implementation of quality findings. And implementation sciences has also really grown up over the last decade, and still itself also growing. There's also just the beginning of training standards that's going to need to build up. You can build a workforce, but you also have to train them and have an appropriate cultural transformation for them. There's already been reference, I think appropriately so, to things like universal precautions, to things like teach back. And I appreciate, Dr. Koh, that you mentioned these core principles. But it's actually going to be a cultural transformation that's going to have to take place for the workforce, all the clinicians, to be able to endorse and embrace that and see that as part of its mission. And so I'm going to leave you with the following, which is that we're beginning to do these things, but it's not done. The work is not done. The day is long, but and the work is not done, and we're not permitted to step away from it. But we're not going to probably finish it anytime soon. So we're going to have to massively increase education and support, both for patients and also for clinicians, for how patients and families and social networks use and understand and access and behave. And then also on the other side, how health systems can be activated and empowered to deliver a decent product. Massively reduce unnecessary complexity. I think that was one of the dominant themes for the previous panel, is about all the unnecessary complexity in the medication space. But yes, it's true, and that's one of the most complicated scenarios for people. But really, there's unnecessary complexity up and down our whole system. And then we have begun to see the emergence of policy at appropriate leverage points to move the needle in some areas. Policy that actually has teeth will have a bigger impact than just, unfunded mandates. And so figuring out where to put additional leverage points to promote health literacy behavior really up and down the spectrum is going to be critical. But we have already started to see this happening. And so it's actually quite optimistic to be standing here. My personal example, and the one that I've been working hard on in a lot of ways, is that a decade ago, when I went to the heads of a hospital, I would say things about readmission, and they would look at me and they would say, "You're going to have to leave. We're paid to keep the beds full. And this is not good for us to talk about this topic." And that's actually completely transformed. You can legitimately talk to a hospital about this topic, and it's actually something that has transformed, and it's been a cultural transformation. Policy was key, and that's one of the in a great example. But we really haven't seen, for example, a change in policy for high stakes testing. You can't leave medical school without understanding how the kidney works to a certain extent, and yet most places you can leave it without understanding some basic communication principles. And it's part of the curriculum, it's emerging, but it's not yet high stakes testing. And in the end, that's what's going to end up moving the needle. So thank you very much.